The lungs are the only respiratory organs that are involved in the gaseous exchange of oxygen and carbon dioxide. The extremely thin barrier between inspired air and the blood circulating within the pulmonary capillaries is called the air-blood barrier. To keep this barrier functional, the air-conducting passageways condition inspired air in three different ways. First, they thermoregulate it to body temperature. Although this usually involves warming it because we usually breathe air that is cooler than body temperature, sometimes the conducting passageways must reduce the temperature of incoming air. Second, the air is moisturized to 100% relative humidity. This prevents desiccation of the alveolar linings of the lungs. Finally, by secreting a thin layer of mucus, the conductive passageways clean the inspired air by entrapping dirt and dust particles in the mucus. This dirt-laden mucus is subsequently swept up and out of the air-conducting passageways by ciliary action.
Hi, I'm Mike Shively. Welcome to Introduction to Anatomy and Physiology. We're currently talking about the respiratory system, and we're kind of in the middle of that system. Does anybody have any questions before we continue today? Eva?
I was just wondering, you said one of the things that happens to air when you inspire it is it gets cleaned by the particulate matter being trapped in the mucus in your respiratory passageways. I was wondering, wouldn't they just kind of get full eventually? How do you get that stuff out?
That's a good question. The lining mucosa of the air-conducting passageways actually has ciliated cells. I don't know if you recall from a session a long time ago when we talked about classifying membranous epithelium, but we talked about one of the special kinds of membranous epithelium was pseudostratified columnar epithelium lining the respiratory passageways. Well, it turns out that those pseudostratified cells are ciliated, and the cilia beat in an upward, if you will, as far as the respiratory passageways are concerned, direction. And that slowly but surely moves that dirt-laden mucus up and out. Obviously, if it weren't for that, you know, if we were in a dusty environment very long, you know, we would clog up. Now, you can exceed the capacity of the ciliated mucosa to move dirt up and out. If you're in a real dirty, dusty environment, you know, coal miners, for example, you know, they classically have problems with coal dust, the very fine particulate matter, finally just getting embedded, if you will, in the walls of some of the air-conducting passageways. Smokers have the same kind of problem. Over in the gross lab, for example, when we open up a cadaver, it's pretty easy to tell if this individual was a smoker during their lifetime versus a non-smoker, because smokers will have much darker colored lungs, because the small air-conducting passageways will have some of the cigarette, the tobacco tars and so forth that are dark colored that are embedded in their walls.
Okay. Just on that same note, you said it sweeps it up and out. Now, I notice, like, maybe when I have a cold, I'm coughing up a lot of yucky stuff, but on a normal day, I'm not usually spitting out a lot of dirty, nasty-looking stuff all day. Where up and out to where? Where is it going?
Well, what happens, of course, it comes right on up through the larynx, and then we actually swallow that material.
Oh,
now, if you've been in a real dusty environment, okay, for a whole day, that night or the next day, you'll notice more garbage working its way up and out. If you have a certain kind of respiratory infection or so forth, you may have a lot of mucus and so forth, extra mucus that's being produced as a result, and you'll notice more movement of that sort of material. Obviously, if you're healthy and you don't have any kind of infectious process going and you're breathing a relatively clean air, then you'll have less of that sort of thing going on. But yeah, it actually gets moved up out of the air-conducting passageways, and we typically swallow it, or in some cases, if there's a lot of it, you know, we can spit it out. So okay. That's how that happens, and you hope that works, you know, fully functionally during your lifetime. The mucus-producing cells, the ones that actually produce the mucus, don't go quite as far down the air-conducting passageway as the ciliated cells. If you stop and think about that, that's logical, because if we had mucus being produced further down than the sweeper cells, then the dirt-laden mucus further down there would have no way of getting elevated up and out. Any other questions about the respiratory system? Bryce?
Now, you also said that while the body tries to take air to 100% relative humidity, so if you're like breathing steam or like misty air that's got lots of water in it, how does that affect it?
As a matter of fact, sometimes respiratory therapists will put somebody that's having a real infection problem with congestion on that regimen exactly, because I don't know if you've ever had the experience, if you have a real bad, quote, chest cold where you have a lot of lung congestion, if you get in a hot shower and breathe that warm, moist air, it tends to loosen up some of the congestion that you have and make it easier for the ciliated cells to move it up and out. All right, I want to go back to something that we were talking about kind of when we ended up last time. We were breathing normally, and I said that when we inhale and exhale, however much air that we're taking in and exhaling, we call that the tidal volume. And then we all admitted that we could inhale, you know, if we're at rest, we could inhale more air than what we're bothering to at the moment. We called that the inspiratory reserve volume. We could exhale a larger volume of air than we're bothering to do at the moment. We called that expiratory reserve volume. And then right at the end of our previous session, we said that there's some air that we simply cannot move out of our lungs, and that's called the residual volume. Let's go to the overhead camera and take a look at those 4 volumes one more time. These are considered to be by physiologists the 4 respiratory volumes. And again, this one right here, the tidal volume, is the one where we're inhaling and exhaling. However much we're moving in and out at the moment, that's considered to be the tidal volume. Obviously, if you're doing heavy, strenuous exercise, your tidal volume will be much smaller than if you're at rest. Let's just label these 1, 2, 3, and 4. We'll say that's number 1, this is number 2, this is 3, and here's 4. If we add all 4 of those together, physiologists call this the total lung capacity. All 4 volumes added together. If we add together just the top 3, number 1, 2, and 3 on our list here, that's called the vital capacity. They even have names for the top 2 added together and the bottom 2 added together. They call this the inspiratory capacity, and these 2 added together functional residual capacity. But the 2 that I really want you to remember as far as capacities are concerned, total lung capacity and vital lung capacity. So the only difference between these 2 is this one includes the residual volume, this one does not include the residual volume. Now, for a given individual, the total lung capacity remains relatively constant once you reach adult stature. If you work at it hard, you can make some slight changes to it, but basically that's the same. But during different periods of varied activity, obviously there can be some changes within this. I mentioned already that if you start exercising very vigorously, your tidal volume will get much larger. But as your tidal volume gets larger due to heavy exercise, your inspiratory reserve volume and your expiratory reserve volume get correspondingly smaller. So that the total lung capacity and the vital capacity basically remain unchanged, even though the various volumes within that make it up may undergo considerable change depending on your level of activity. Anybody have any questions about these 4 volumes or those 2 capacities that I want you to remember? Bryce?
Like some people have breathing exercises that they do in order so they can like stay underwater longer or something. So how does that affect?
Hyperventilation.
Well, probably more than anything else, if you're going to stay underwater longer, you need just practice holding your breath. I don't know if you've ever timed yourself for how long you can hold your breath, but if you practice for a few days in a row, you can get to the place where you can do that considerably longer. It has to do with tolerating more. It's not that you're not changing the amount of air you're taking in, it's tolerating the pH and CO2 changes that are occurring in your bloodstream as you, in fact, hold your breath. You can teach yourself to tolerate that to a greater degree. What was that movie that came out not too long ago involving, they were deep sea divers?
Men of Honor.
Men of Honor, yeah. Do you remember that scene where they were having the little contest and they got in their diving masks and so forth, and we're having a contest between the 2 of them to see who could hold their breath the longest. Kind of interesting scene. Kind of dramatic. I don't think I'd want to have that headgear on me and have it fill up with water personally. Let's do something else before we begin the actual discussion today to kind of pull together some of the things that we talked about the other day. I want to go to the overhead camera here for just a moment, and let's put a little tiny heart. This is about as big a heart as my students say that I have. Now, I want to, so let's just go ahead and label that H-E-A-R-T, just to remind ourselves what it is. The heart actually has a little tiny sac around it made of serous membrane. Part of that serous membrane is actually adherent to the surface of the heart. And then up here at the base it kind of reflects out and comes around. And if you think of that as being a soft red balloon, then we could actually just imagine the heart kind of being shoved down into the top of that balloon. The name of that serous membrane is pericardium. I'm going to write it way up here. P-E-R-I-C-A-R-D-I-U-M. Pericardium. And there's a little tiny bit of fluid in this sac, and that's called pericardial fluid. The space itself is called the pericardial cavity. So pericardium is the name of the serous membrane. Pericardial fluid is a little tiny bit of fluid that's in there, and the space in which the fluid is found is the pericardial cavity. Now that fluid exists probably to lubricate the outside of the heart and make sure that it's not rubbing holes in the lungs, which it lies next to during the contraction relaxation phase. There's movements of the lungs and movements of the heart, and without these serous membranes, a little tiny bit of fluid between them to serve as a lubricant, in fact there could be some irritation and perhaps even eventually some damage. Now, let's go back to this drawing, because what I want to do is I want to actually draw the lungs around this heart. So, and we're going to leave a little tiny bit of space to help us with some other serous membranes that we're going to put on here. So we're going to say that's our misrepresentation of a lung. And we'll put another one on over here, kind of similar shape. And the lungs have serous membranes associated with them as well. I want to go ahead and put a line over here and say that's the chest wall, and this is the chest wall, and we'll even draw a little diaphragm down here. And just to kind of give a little more perspective, let's bring what we'll call the trachea in Of course, we put little lines across it. We can recognize those as tracheal cartilages, perhaps. And then we'll split principal bronchi off and have a principal bronchus going into each lung. What I want to do is I want to draw the serous membrane that's associated with the lungs. And there's a layer of it that's right on the very surface of each lung. This goes all the way around the lung. If you participate in this little pencil and paper activity, I guarantee that it'll increase your understanding of points we're going to try to make here in a moment. And then the stuff goes over here and reflects down on the chest wall. And then it comes across the top side of the diaphragm. When it gets over here near the mid-sagittal plane, it reflects up and comes out on the outside of that pericardium. It kind of does that. Same thing happens over here. We've got the serous membrane on the outside of the lung. Up here it comes up and reflects onto the chest wall. Comes across the top of the diaphragm. Goes up and is closely associated with the pericardium. Now the blue lines, I don't know how well you can see the color, but these blue lines that we've just drawn, that serous membrane is pleura. P-L-E-U-R-A. In fact, the pleura that's on the lung is called pulmonary pleura or visceral pleura, and all the rest of this pleura is called parietal pleura. Anatomists will actually divide the parietal pleura into that that's on the rib cage. They'll call that costal pleura, referring to ribs. This parietal pleura that's down here on the diaphragm, they'll call diaphragmatic pleura. And this that comes up, surrounds the pericardium and heart and so forth, this is called mediastinal pleura. Now, last time we mentioned the mediastinum, I want to write the word down here. And mediastinum is actually the partition between the two lungs that's formed by these layers of mediastinal pleura, the pericardium, the heart, the esophagus that I haven't drawn in there. There's some large blood vessels in there. But the two lungs are completely separated from each other. In other words, there's a partition that goes right down the middle of the thoracic cavity that completely divides one side from the other side of that thoracic cavity. And over on this side we have this lung, this principal bronchus. Over on this side we have this lung and this principal bronchus. And then the heart and esophagus and those sorts of things are actually within that partition that we call the mediastinum. Now I've drawn a bunch of space. I'm going to put some X's in this space right here. We've drawn the space a lot bigger than it actually is. But this space in which I'm putting blue X's would be the left, assuming we're looking from the front, would be the left pleural cavity that surrounds the left lung here. The lung is actually invaginated into the cavity without being inside of it, in the same manner that this heart is kind of shoved down into this pericardial cavity, but is not truly inside of it. If you'll imagine with me a soft balloon, take your fist and shove it into that soft balloon. Your fist would be invaginated into the balloon, but would not be inside of the balloon in the same sense that the air would be. And that's the same kind of physical relationship that we're talking. If we go back to the overhead camera for just a moment here, the heart being shoved into the side of the pericardial cavity, but not being inside the cavity itself, like these dots are, okay? And the lung and principal bronchus here being shoved into the pleural cavity, but not being inside of the cavity itself, like where the blue X's are. At any rate, we've got the same thing over here. This space on this side would be the right pleural cavity. And again, I've tremendously exaggerated the space just so that we can more easily see it. So we have basically spaces that have a little tiny bit of fluid within them. The left and right pleural cavities, these are called, and the one inside here, the pericardial cavity. Now, I want to imagine just going all the way through this thing with a bullet or an arrow or a hat pin, just kind of like that blue arrow did right there. We would actually cross serous membranes many times. We'd cross one right here on this surface of the lung, on the other side of the same lung. Then the red line and the blue line, I've drawn them as though there's space between them. They're actually adherent to each other like two pieces of saran wrap. So it would be some pleura and some pericardium, then some pericardium, then we'd be in the heart. And then there'd be some pericardium, pleura, 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 and pleura. So that particular arrow, if we pass through like in the direction we've done it there, would actually go through serous membranes many times. Now again, this serous membrane out here is called costal pleura because it's on the inside of the rib cage. The serous membrane on each side of the lung is called visceral or pulmonary pleura. This layer right here that's adherent to the pericardium is called mediastinal pleura. And then that pericardium itself, I don't know if I separated that a while ago, but the outer layer here is parietal pericardium and the inner layer is visceral pericardium. So you can see that there's a bunch of named serous membrane layers that this particular blue arrow, virtual blue arrow, would have to pass through. Now, the spaces that where we have the O's and X's, those pleural cavities, are relative vacuums compared to the outside atmospheric pressure out here. Relative vacuums. And when the diaphragm contracts and pulls downward from its kind of domed position into a more inferior position, like I've implied with these dotted lines, that makes that thoracic cavity and the pleural cavities inside of it larger by becoming longer. And when you take a closed space and make it larger, the pressure in that space drops. And so by contracting the diaphragm, as we mentioned last time, we're actually going to drop the pressure in these pleural cavities, and air is going to rush down the trachea up here and cause the lungs to inflate. And expiration is effected by the opposite mechanism. We relax the diaphragm, abdominal viscera shove everything back upwardly a little bit, makes the space smaller, which increases the pressure, and air is passively forced out of the lungs. Now, what's going to happen if we get a hole in our chest wall out here? You know, could happen with a bullet, could happen with a knife blade, could happen because we have a severe traumatic incident and poke a rib through the chest wall here. Adam?
The lung's going to collapse.
Lung's going to have a tendency to collapse. Let's see if we can see why. Let's go back to this overhead for just a second. If we put a hole right here, pressure in here is lower, atmospheric air will rush into here. The lungs have a natural tendency to collapse. And I think it's important that we remember that particular fact. Left to their own devices, lungs will collapse because they have a lot of elastic fibers in their structure. When we inflate the lungs by inspiring air into them, we stretch those elastic fibers. And then if those elastic fibers are given the opportunity, they will pull back down and cause the lungs to collapse. Another feature that's probably even stronger than the elastic fibers is the thin layer of fluid lining each pulmonary alveolus. Now, we haven't talked about pulmonary alveoli yet. We will here in just a little bit. But that thin layer of fluid has a natural tendency to cause each pulmonary alveolus, each air sac within the lungs, to collapse, if you will. And so the lungs also have a tendency to collapse because of that thin layer of fluid. So it's surface tension of the fluid lining the alveoli and elastic fibers within the pulmonary parenchyma that make the lungs have that tendency to collapse. So if I get the hole in the chest wall and air rushes in there, that lung is going to have a tendency to collapse. What do we call a condition where we have air inside a pleural cavity?
It's a pneumothorax?
Pneumothorax. Pneumothorax. Now hopefully if the mediastinum is intact, the other lung will not be collapsed and we'll still be able to breathe, although we will be in trouble. We will be in what we call dyspnea, difficult breathing. Difficult breathing. Now, is that the only way that we can get a lung to collapse, by getting a hole in the chest wall? Let's go back to the overhead. Could we forget, if we go to the overhead camera, could we forget to wear our seat belt and actually get slammed up against the steering wheel hard enough to get a ruptured diaphragm and some abdominal viscera go up into a pleural cavity? Sure. Sure, we call it diaphragmatic hernia. Due to a traumatic incident, we get a bunch of intestine, liver, stomach, intestine, go up there and say, hello, lung. And what happens? lung on that particular side collapses. Another thing that can happen, go back to the overhead camera one more time, we could get a hole in the lung. Here, let's repair this diaphragmatic hernia here real quick. You know, we can do surgery real quick on this screen, can't we? And we'll repair this hole in the chest wall over here as well. We get a hole in the lung, and the air within the lung itself will come out into the pleural cavity. Okay? So all of those situations will cause a collapse of that particular lung. Now, there's other things that can occupy space in a pleural cavity besides air and abdominal viscera. We could have severe hemorrhage into a pleural cavity. We'd have blood in there, perhaps due to some traumatic incident, bullet wound or broken rib. And we can get a bunch of blood in there. That would be called a hemothorax if we had blood in there. Pneumothorax if it's air, hemothorax if it's blood. We could even tear a hole in one of the very large lymphatic ducts that we talked about on a previous session, the thoracic duct or the right lymphatic duct, and get a bunch of lymph leaking out into a pleural cavity and get what's called a chylothorax. Chylo, C-H-Y-L-O, thorax. Or we can get pus, if you will, in a pleural cavity and get what's called a pyothorax. So at any rate, I just wanted to go over the physical relationship, and I wanted to stress on this drawing that what we mean by mediastinum is that partition in between that separates those two lungs from each other. Any questions? Yeah, Adam?
If you get one of these conditions, how do they reinflate the lung?
Okay, first of all, we have to correct the problem. If we've got a hole in the chest wall, we have to close the hole in the chest wall. And so that's obvious. So we're going to correct the problem. As they correct the problem, most of the time surgeons will draw out physically as much air as possible. They can use a giant syringe, and perhaps they'll even leave a tube through the chest wall. It's closed when they're not sucking air out of it. Residual air, small amounts of air though, will be reabsorbed over time. So if you get a spontaneous blowout of a lung, they may not do anything, because it'll quite often heal itself. Not do anything except monitor you, and as long as your respiration is under control and you're okay, they'll just wait, and within a few days that air will reabsorb. Any other questions? All right, let's do this. Let's go to a graphic here that separates respiration into three different concepts. Quite often when we think about respiration, we're thinking about inspiration and expiration. And those components, or that part of respiration, is called ventilation. Physically moving air into and out of the lungs. But another component of respiration is O2-CO2 exchange at the lungs and out in the tissues. And finally, to a cytologist or a cell biologist, the oxygen utilization out in the tissues themselves by an individual cell is what they would think of when they think of respiration. So think movement of air, O2-CO2 exchange, and then the actual utilization of oxygen to form eventually carbon dioxide and water as glucose is being burned as the three components of respiration. Last time we mentioned the diaphragm, and mentioned just a bit ago as well, in as far as contraction and making the thoracic cavity longer. I want to bring up a model, and I want us to kind of look. I'm going to tilt this model up, and we'll look at it on the overhead camera. First of all, we'll get it in this orientation so you can see we're looking at a lung model with a heart on it. We're going to look underneath and look at the diaphragm. So we just lost a lung, but we'll be okay. There we go. See how quick, what a good surgeon I am, huh? We're looking at the underneath. We've got kind of an abdominal visceral view looking upward at the bottom side of the diaphragm. And it is a partition formed of skeletal muscle tissue. It's got a central kind of a tendinous or aponeurotic area in its center. And it has 3 passageways through it. You can see one right here, which looks like a black hole. You can see another one right here, which has what looks like the aorta passing through it. And we finally have one right here, which has a structure that I can tell, because I'm close enough to see it, is supposed to represent the esophagus. So there are actually only 3 passageways through the diaphragm. Now this one over here that looks like a black hole only transmits one anatomic structure. And the structure that passes through that part of the diaphragm is the inferior vena cava. That's the large systemic vein that's returning blood toward the heart from the lower part of the body. That passageway is called the caval foramen. Caval foramen. Sometimes if you look at the Latin, it could actually be translated vena caval foramen. This passageway right here, which transmits the esophagus, also transmits a couple of the vagal nerve trunks from the left and right vagus nerves. Now, vagal nerves were cranial nerve number 10, if you'll recall from a few sessions ago. Now, the model doesn't actually show those coming through, but I'm just telling you that in addition to the esophagus coming through here, we've got the vagal nerve trunks. The name of the passageway is the esophageal hiatus. I'll write that word, we'll actually look at it on a graphic here in a minute. And finally, coming through this opening, obviously, is the aorta, but there are 2 other structures that accompany the aorta through this opening, and that's the azygous vein. And does anybody know the other one? Eva?
The thoracic
Thoracic duct, you bet. So we have actually 3 structures coming through here. The name of the opening is aortic hiatus. It transmits the aorta, the azygous vein, and the thoracic duct. Now, I know I didn't put those names down in writing for you. Let's go to a graphic that will illustrate those. There's the names of the passageways, and in kind of reverse order from the way we did them. Aortic hiatus transmits aorta, azygous vein, and thoracic duct. Esophageal hiatus transmits the esophagus and the vagal nerve trunks. And the caval foramen, also called vena caval foramen, transmits the inferior vena cava. So there's not as many things actually going through the diaphragm as a lot of people might suspect. There's a couple things that kind of sneak over the back side of it without actually penetrating through actual holes or passageways, and those would be the sympathetic trunks, left and right sympathetic trunks. And obviously the spinal cord goes, you know, from up here to down there, but it's buried in the body wall, if you will, because it's passing through the middle of the vertebral canal. And so it doesn't obviously go through the diaphragm itself. Now, one of the things we haven't talked about in lungs is we haven't talked about the actual little air sacs. We've talked about them, or mentioned them in passing 2 or 3 times, the pulmonary alveoli. And I want to go to an overhead camera here and kind of draw what we're talking about. We get the little, and we have to be think microscopic now, think very, very small. We get these little tiny passageways that are called bronchioles. They come down here and finally end, and I'm going to enlarge this, each smallest bronchiole ends in a little air sac, if you will, and this air sac is a pulmonary alveolus. A-L-V-E-O-L-U-S, pulmonary alveolus. Air sac would probably be an easier way to think of it. Most of the wall of this is made up of simple squamous epithelial cells. They're flattened out. So I'm just kind of trying to make this drawing look like we got little flattened cells. They're kind of hooked together edge to edge. Those cells are called respiratory epithelial sites. Respiratory epithelial sites. We'll We'll look at a graphic for the spelling on that in just a minute. Interspersed among them, and not nearly as numerous, are some more globular-looking cells. That produce a surface tension reducing agent called surfactant. Now, these cells are actually called granular epitheliocytes. But an old name for the first one is type 1 pulmonary alveolar cells and type 2 pulmonary alveolar cells. I'm going to put these up here. I'm going to put them both in quotes. And the type 1 are the flattened cells, and the more globular ones that produce the surfactant are the type 2. You'll see these in the literature quite a bit, in fact. A lot of physiology texts will have type 1 and type 2 pulmonary alveolar cells, as opposed to the proper names, which I'll show you on a graphic in a moment. Finally, a third type of cell that's found in a pulmonary alveolus is a macrophage, a phagocytic macrophage. Now, there'll be another alveolus right next to this one, same structure. Another alveolus right next to it, same structure, and so forth. In between adjacent alveoli will be capillaries. I'm just going to stick one right in there in transverse section. So it'll be capillaries. Matter of fact, there's a network of capillaries surrounding each alveolus, kind of jammed in between it and adjacent alveoli. And the things that oxygen and CO2 have to diffuse through to get from the air here to the bloodstream there, or from the bloodstream there to the air here, are extremely thin. And they constitute what we call the air-blood barrier. The things that O2 and CO2 have to diffuse through make up what we call the air-blood barrier. And it's commonly written like this, hyphenated, air-blood-barrier. Let's go to a graphic and take a look at the cells in a pulmonary alveolus. I mentioned them, but here you can see the spelling. Type 1 pulmonary alveolar cells, the proper name for those is respiratory epitheliocytes, that first name up there. Respiratory epitheliocytes. They are simple squamous epithelial cells. The type 2 pulmonary alveolar cells, the proper name is granular epitheliocytes, and you can see that name. They're the ones that produce surfactant. Surfactant is a surface tension reducing agent. And then finally, macrophages is the same way we wrote it before. Now I want to call your attention to that second cell, the granular epitheliocytes that produce the surfactant. If it weren't for the surface tension reduction that lipoprotein called surfactant imparts to the thin layer of fluid lining each alveolus, we wouldn't be able to inhale. We wouldn't be able to inspire, simply because the lungs would have such a strong tendency to collapse that we wouldn't be able to inflate them. Surfactant is not produced by an infant in gestation until very late in this cycle, very close to birth, and that's one of the reasons why premature infants have such a difficult time breathing, is because if they're several weeks premature, they may not be producing adequate surfactant at that time to reduce the surface tension enough to allow inspiration to occur. I want to go to the next graphic here that summarizes what we mean by air-blood barrier. It's extremely thin, and it separates the air within an alveolus from the blood in the surrounding capillaries. Now, there's really only three things that contribute to it. The respiratory epitheliocytes on the air or pulmonary alveolar side, those are simple squamous epithelial cells. a little tiny bit of connective tissue proper between that and the lining epithelium called endothelium of the capillaries themselves. So we're talking about an extremely thin layer of stuff that separates air and blood. Very, very thin. That's one of the reasons why under extreme environmental conditions, like if you're inhaling really cold air, you can actually damage the the lining cells of your lungs, because it's such thin cells, and you can actually get some pulmonary hemorrhage under certain circumstances. Or the climbers that are going up Everest, they get into pulmonary edema when they get into the real low air pressure of high altitude and cannot remain in what they call the death zone very long. Any questions about what we mean by air-blood barrier or pulmonary alveoli? Or Eva?
I was just wondering, you mentioned the function of the type 1 and type 2 cells, as you called them, but why are the macrophages there?
Macrophages are there. They're looking for trouble. They're wandering phagocytic cells looking for bacterial invaders. And obviously we take in a lot of bacteria in the air that we breathe. So that's their functional purpose. Any other questions? Bryce?
You talked about the lungs and how they're divided into 3 lobes before. You said that some of them can collapse. Can you remove parts of those, or do you have to take out the whole thing if they're damaged that bad?
It's possible for a surgeon to remove a lobe of a lung. Now they can even remove parts of a lobe of a lung, but usually, quite often, if you've got cancer or severe damage to that particular part of a lung, they'll remove a whole lobe in many cases. They can remove a whole lung, obviously. You can still function, although you're not going to be an endurance athlete, because we have considerable safety net built into our respiratory capacity. Hazel, do you have a question?
Yeah, I did. What happens when people have asthma?
Asthma is a involuntary constriction of some of the smaller bronchial passageways. It has some hypersensitivity overtones with it, and so those individuals may have to inhale bronchodilators in order to get those passageways to open up enough for them to breathe normally. All right, let's talk about hemoglobin a little bit. We mentioned it in passing when we were talking about the cardiovascular system. It is the oxygen-carrying, red-colored pigment that's found in red blood corpuscles. And obviously that's going to be extremely important in the whole respiratory process. Let's go to a graphic here that summarizes its structure a little bit. There are 4 protein strands, that makes up the globin part, and 4 heme molecules. In each one of those heme, and they're actually kind of complex, each heme molecule is relatively complex. But among the parts of it, each heme contains 1 ion of iron, and each one of those ions can bind 1 molecule of oxygen. Now, that means we can bind a total of 4 molecules of oxygen with 1 molecule of hemoglobin. 1 molecule of hemoglobin can bind 4 molecules of oxygen. Now let me give you some mind-boggling gee whiz figures here in this next graphic. A red blood corpuscle contains about 280 million molecules of hemoglobin. 1 red blood corpuscle, 280 million molecules of hemoglobin. And since each one of those molecules of hemoglobin can carry 4 molecules of oxygen, you've got over 1 billion molecules of oxygen in 1 red blood corpuscle, if that red blood corpuscle were fully saturated. Now, they're typically not fully saturated, but they'll be in the 90-some% fully saturated. But at any rate, it is a tremendously large quantity of individual oxygen molecules that a single red blood corpuscle carries. And when it enters the pulmonary capillaries surrounding each alveolus, the percentage of oxygen is pretty low when it's coming in, from the heart, and the blood's being pumped into the lungs. Each red blood corpuscle has a very low percentage of oxygen. And then in the split second that it's within a pulmonary capillary, it becomes over 90% saturated with oxygen. Let's look at a graphic that summarizes what's going on with oxygen in the lungs and in the tissues. The unoxygenated form of hemoglobin is called deoxyhemoglobin. And if you take that to the lungs and add oxygen to that deoxyhemoglobin, then we form the oxygenated portion or form of hemoglobin called oxyhemoglobin. So in the lungs, this is converted to this, deoxy to oxyhemoglobin. Now exactly the opposite thing is going to be happening out in the tissues of the body. Oxyhemoglobin is going to be converted back to deoxyhemoglobin because why? Because it loses its oxygen out there, and that oxygen is utilized by the cells and tissues. So that's the basic change that's occurring. This is what happens in the lungs. This is converted to this, and out in the tissues, this is converted back to this. Eva, you have a question?
Yeah. If the oxygen is carried through the blood by the hemoglobin, what carries the carbon dioxide?
We're going to talk about that in just a second. Hang in there. It'll come up in just a second. Now, hemoglobin has a strong affinity for oxygen, and so it becomes over 90% saturated in that split second that it's in a pulmonary capillary. It has even a stronger affinity for carbon monoxide, CO, carbon monoxide. And so if you're put in a situation where the carbon monoxide levels are reasonably high, your hemoglobin will bind selectively to carbon monoxide because it's a more attractive molecule to the hemoglobin than oxygen is, and your blood will then be carrying perhaps such a small amount of oxygen that you won't be able to survive. We had a neighbor down in the Springville area, had one of those cars that you can hit the button and start the car remotely. You with me? And evidently he started his car and kind of forgot that he started his car or something. Anyway, they went to bed that night. He might have actually hit the button accidentally. I know I've hit my panic switch on my little beeper, you know, time or two, and my car jumps around and makes noise and calls attention to itself. But at any rate, went to bed, went to sleep. Carbon monoxide levels got so high, came up from the level down below where the garage was, came up through the house. And he passed away, and his wife was in severe difficulty simply because of carbon monoxide levels getting too high. At any rate, let's take a look at that reaction. Go to this graphic. If you take deoxygenated hemoglobin, deoxyhemoglobin, and add carbon monoxide, CO, then it forms a compound called carboxyhemoglobin. And this stuff is somewhat stable. It's kind of hard to break the CO out of this, so it just ties up all of your hemoglobin, and then you basically have too small amount of hemoglobin to carry oxygen, and so your tissues become oxygen starved. Now, Eva, you asked about the way that CO2 was carried in the bloodstream. Let's take a look at this next graphic, which summarizes that. In fact, about 10% of the carbon dioxide now is in the form of dissolved CO2, simply dissolved in the plasma of the blood. Hemoglobin will bind also to carbon dioxide. This is not nearly as strong a bond. That combination is called carbaminohemoglobin, and about 20% of the carbon dioxide is carried in the form of carbaminohemoglobin. And then about 70% of the CO2 is carried in the form of bicarbonate ions. So 10%, 20%, 70%, you add those up, that's essentially 100%. That's the way that CO2 is transported back to the lungs within the bloodstream, either dissolved, attached to hemoglobin, or in the form of bicarbonate. Now let's review a reaction here. We may have looked at this a long time ago in a previous session, but we'll go to the next graphic. And and take a look at what happens when CO2 is produced here in the tissues of the body. A large percentage of that CO2 will combine with water molecules, CO2 plus H2O, and make H2CO3. You all know that this is carbonic acid, H2CO3. Now, carbonic acid is in a reversible reaction that will break down into hydrogen ions, and this is bicarbonate over here, HCO3. So we have this equilibrium within our bloodstream. As we exercise and produce more CO2, it drives everything to the right because of the equilibrium status. Now, if you keep driving everything to the right, you get a lot of this. And H plus, of course, acidic radical. This is what we measure when we measure what? pH, right? As the concentration of hydrogen ions goes up, what happens to the pH of the bloodstream? It goes down because there's an inverse relationship between hydrogen ion concentration and pH. The higher this is, the lower the pH. So if you have a blood pH of 7.40 before you get on the treadmill, and then you work out really hard on the treadmill or biking or whatever you're doing, then that hydrogen ion concentration is going to increase. Your blood pH is going to go down. You're going to start breathing harder and faster to get rid of the excess CO2. Obviously, over in the lungs, if you're breathing off the CO2 and exhaling the CO2, you tend to drive that whole set of reactions back to the left in the other direction. So that's an important dynamic in respiratory physiology, is that particular set of reversible reactions. I want to take a look at a graphic which shows kind of an interesting comparison between atmospheric air versus the air that's in a pulmonary alveolus. And we're looking at these four things. We're looking at water, CO2, oxygen, and nitrogen total concentration. Now, we're going to assume that we're at 14 pounds per square inch or 760 millimeters of mercury pressure, so we're at sea level. The amount of water in the air, of course, is going to vary depending on what the humidity happens to be. CO2 is very, very low in the atmosphere. See, it's 0.3 millimeters of mercury out of a total 760 here. And the oxygen is about, roughly 20% of the total pressure, and nitrogen is about roughly 80% of the total pressure. Now, if we go to the air within a pulmonary alveolus, we're up at 100% relative humidity, which raises the partial pressure due to water up to 47 millimeters of mercury. The CO2 increases dramatically because CO2 is, quote, coming out of the bloodstream into the pulmonary alveolar air. The oxygen level goes down considerably because we're absorbing oxygen. And the nitrogen level goes down a little bit, even though we're not absorbing nitrogen per se, because the water content came up, it forced the nitrogen percentage-wise down. So I think that's kind of an interesting graphic comparing atmospheric air and air in a pulmonary alveolus. And it's basically related to the humidification effect and the fact that oxygen is being pulled out of the air into the bloodstream within pulmonary alveoli, whereas CO2 is coming the opposite direction. It's coming from the bloodstream out into the pulmonary alveolar air. Now I want to ask you some questions, and let's go to this next graphic and let's see if we can answer these questions one at a time. What's the effect of low CO2 in your bloodstream? This is blood CO2. Effect of low CO2 on ventilation. In other words, if we measure your blood carbon dioxide content, and we say, hey, that's pretty daggone low, are you going to be breathing hard and fast, or are you just going to be breathing really easy and relaxed? Adam?
Slow and shallow.
Slow and shallow. If your CO2 levels in your bloodstream happen to be low, you don't need to breathe real hard right now because you don't have excess CO2 to get rid of. Now, on the other hand, if we go back to that same graphic, if the CO2 levels are pretty high, maybe you've been exercising. Maybe you've been burning a bunch of glucose and producing CO2 in water. And if you've been exercising and producing enough CO2 to get high blood levels of CO2, you're going to be breathing hard and fast, aren't you? Going to be breathing hard and fast. Okay, low pH. Low pH. Eva, what's the effect of low blood pH?
Going to basically be the same effect as high CO2.
Going to be the same effect as high CO2. So if your blood pH is low, you're going to be breathing pretty hard and fast, aren't you? Because you're going to have high CO2 in your bloodstream, and you're going to need to exhale that excess CO2. And then, of course, the opposite's going to happen if the pH is high. Go back to the graphic one more time. Interestingly, if your blood oxygen levels are relatively low, there's not very much effect on your respiratory rate. In other words, your body doesn't monitor what the oxygen levels are. It monitors what the CO2 levels are and what the pH is. If the CO2 levels are in the correct range, if the pH is in the correct range, then that's all that the body really worries about. Because with our atmosphere, having the proportions of oxygen and CO2 that it does, if your blood plasma levels are where they need to be, then then your oxygen levels are going to be okay as well. I don't know if that makes any sense or not. Quite often when we, like if we hold our breath, let's everybody hold your breath, and you know that pretty soon you get to the place where I got to breathe. You have that, you almost get panicky when you're in a situation. Like if you're underwater, you certainly kind of get panicky. And the thing that's happening there is not low oxygen. Yeah, your oxygen levels are dropping down because your tissues are using them up. But the thing that is making you have this real strong tendency to want to inhale under those circumstances is the low pH and the high levels of CO2 that are developing in your bloodstream as you hold your breath. Does that make sense?